So as everyone's getting a seat, thank you all so much for coming. My name is Deborah Volleson, and I'm the Director of Patient and Community Experience for Kaweah Health. And before I bring up the board member, Armando, I just kind of want to go over the order of events. So on your seat, you have a question card. You can write notes on it. There will be a time in just a few minutes where we will open it up to questions and answers. And at that time, you can either stand up and ask your question yourself, or if you want to slip us the card, we will ask your question for you. But I'm going to introduce Armando, and then he's going to welcome the panelists, and then they're all going to have a few minutes just to talk about what they are doing in their areas. So the rules of this event are also on the back of that question card. So we just asked everybody, we're open to all questions. We just ask that they are asked in a respectful manner. Okay, so at this time, it gives me great pleasure to introduce Armando Murrieta, our Kaweah Health board member. Armando represents Zone 5, and he has been on the board since 2024. His board committees include academic development, human resources, patient experience, strategic planning, and marketing and community relations. But his real job, when he's not at Kaweah, is he's a manager at Self-Help Enterprises. So Armando, come on up.
Thanks. Okay. All right, so you guys gotta bear with me a little bit. A little nervous, so I'm gonna try my best. So good evening, everyone, and thank you for joining us tonight at our Kaweah Town Hall. It's been a little while since we last had one, so thank you again for being here. I also wanted to thank our community engagement team for putting this event together tonight, so thank you. Like Deborah said, my name is Armando, and I have the honor of serving as a board member representing Zone 5 of the Kaweah Health District.
You might want to take it out because they can't hear you.
Oh, okay. Sorry. So I was born and raised here in Visalia. I grew up here on the north side. I went to preschool here. When this was the North Visalia Community Center, so a long time ago. My teachers were Teacher Julie and Miss Madrid, so it was a long time ago. And currently I work at Self-Help Enterprises, and I'm married to my wonderful wife, Karen. We have 3 dogs, and if you guys want to see pictures afterwards, we'll be more than happy to share them, just throwing it out there. And the reason I chose to run for Kaweah Health Board of Directors was because I felt in my heart that I wanted to give back to the community that helped raise me. And I want to make sure our voices are heard and that everyone has access to equitable, high-quality health care. We are so thankful to all of you coming out, and I wanted to make sure I introduce the community leaders we have in the room. We have Dr. Dean Levitan. He's also on the Kaweah Health Board. He's with us here today. We have some of our community advisory council members that are here in attendance also. We also have Mike Olmos. He's the president of the Kaweah Health Board. He's in the room as well. And we have Kyle Savage from Senator Grove's office here with us tonight too. And we also have Ashley Olivas. She's with Assemblywoman Ali Macedo's office. So I'm really excited to be joined tonight by a great group of Kaweah Health leaders who bring incredible knowledge and heart to what they do every day. First and foremost, we have Gary Herbst, our Chief Executive Officer. Dr. Terese Hammond, who specializes in pulmonary and critical care medicine. Schlene Peet, our Chief Nursing Officer. And finally, Cameron Beatty, our Emergency Department Nurse Manager. So now I'm going to hand it over to the panelists and let them all speak a little bit about what they are doing in their specific areas and things that they are working to make sure you receive the best care if you are a patient at our organization. So thank you. So I think you guys got a mic up there.
Take your first one. Hi, everyone. Again, my name is Schlene Peet. I am the Chief Nursing Officer. After about 20 years of working as an interim healthcare leader, had the opportunity to come to Kaweah just about 6 months ago. After being at Kaweah for about 4 months, I decided to apply for the permanent role. Very fortunate to be afforded the opportunity to be appointed the permanent Chief Nursing Officer. Very, very happy to be here. Looking forward to improving healthcare and doing everything that I can to make sure that I make Kaweah Health a hospital that everybody can be proud of. I am just super excited to serve this community and to do great things at Kaweah Health. Very excited about just the opportunity to train new nurses and to just provide all types of community healthcare events, and I just love doing all types of things for the hospital, and we've already implemented so many safety initiatives, and I'm just looking forward to all the great things that I'm sure we're going to do at OBBBA with me as the Chief Nursing Officer.
Thank you, Gary. So my name is Terese Hammond. I'm actually the director of the critical care group at Kaweah. So we're sort of the doctors that you and your family don't really want to see, because when you see us, it means that something really bad has happened. And we're the ones that take care of the folks that are the sickest patients of the hospital, patients with heart attacks or strokes or pneumonias. I came to Kaweah just about a year and a half ago. I did all my training in Boston and actually came out to LA in 2012 to be the Pulmonary Critical Care Sleep Program Director at the University of Southern California. So I was down in LA. I did a variety of different leadership roles. I started a lung bypass program at a hospital in the west side of LA that turned out to be very important during COVID, and have really had this appreciation for the importance of community medicine. It's so extraordinarily important that you get care in the place you live. It's important to your families, it's important to you. And by when I moved from USC to the community hospital in Santa Monica, I really started to appreciate that. And I think it became really pronounced during COVID when folks in our community hospital weren't able to get transferred to UCLA or Cedars or USC for a higher level of care. So we had a C-suite, a group of really dedicated administrators that helped us do a lot of those things, including researching therapeutic option and lung bypass technology at our community hospital. When I came to Kaweah a year and a half ago, it was really just to do a job. There was a need. The company that I've worked for a number of years provides clinical care doctors for community hospitals, asked me, and I came in thinking that it would be a temporary thing. But then I met Gary, I met the people in Kaweah. I found this amazing little house in Three Rivers, started to understand how deep the roots are in this community, and I became really entrenched in the idea that this community deserves every bit of my effort, the effort of my team, to provide the same kind of care that you would get at UCLA or Cedars or UCSF. And I knew from the beginning that that's what Gary believed, and that's what he's been doing this entire time, bringing together people that are devoted to offering academic level care in community hospitals. So I'm glad to see so many of my colleagues from the emergency room, from the medicine group. We are, I think, united in a common purpose and have had nothing but support from Gary and the board and the rest of the C-suite in raising and in upping the game, in raising the level of care that we can provide. We have a total of about 12 doctors and nurse practitioners that work in our critical care units at Kaweah, and we all share the same mission. Most people, including a few people that are born and bred in Kaweah or in Visalia, are on our team and want to and feel very gratified by what we're able to, the level of care that we're able to bring you. as Gary and in fact the ward and the C-suite has brought higher level procedures like advanced cardiac surgery to Kaweah, more and more subspecialists that are doing more complex operations or more complex procedures, our role is becoming even more important. So that's what I'm most proud of, that even though I just came here temporarily, I feel very much a part of the Seaport community. And I feel that the collaborations that we're building, led by Gary, by Schlene, by our leaders in the emergency department, by our leaders in surgery, anesthesia, hospital medicine, we're all coming together to try to give you our very best and try to make you proud of your community hospital, knowing that you could go there and get the same level of care with a much more personalized touch than you would get at one of the bigger places. So that's sort of it. Thank you.
Well, thank you everyone for coming out tonight. It's amazing to have this turnout and to hear the voices that go into running our hospital and the district itself. My name is Cameron Beatty, and I'm going on my 8th month here in Visalia at Kaweah. I remember 9 months ago, Schlene called me on the phone, and I was in the gym on a stair stepper, and I said, I'm going to be a little out of breath for this conversation. And she said, that's okay. And I said, okay. And that conversation led to me coming out here, and then having a great 8 months in the emergency room. It's been phenomenal to be a part of this team. Some of the things that we've addressed to reduce wait times in the emergency department, at the end of last year, ED leadership with the provider leadership redesigned our front-end process. Some days, I don't know if everyone's aware of this, we get upwards of 330 patients come through that ED every day. And in order to evaluate everybody effectively and provide high-level care, that you really have to have a well-designed machine there. And so last year, they redesigned the process. And the benefit we've seen from that has been remarkable. Historically, in the ED, the left without being seen rate, which means people that come in and then leave before they're evaluated by a provider, has been anywhere from 1.9 to 2%. We've effectively taken that to half. The last 6 months running, we have not been above 0.9% left without being seen rate, which means patients are being seen in a timely manner, evaluated, and their workups have been started very quickly. The next step is figuring out efficiencies during that workup, and we're working dedicated to do that. But that's been one of the real big successes. As a result of that, our patient experience scores have jumped by 10% basis points within that time frame. And I think Deborah would talk about, I don't think you're supposed to be able to improve that much that quickly per the people that make the rules, but we have done it. We maintain it. Dr. Tu and I talked about this 2 days ago. I think we're actively involved in looking at this. I also have the benefit of reviewing patient comments from our surveys coming through Deborah's team. And I read those and I try to respond in a timely manner, especially when there are things we can intervene on to do service recoveries. And there have been number of times where I loop in Dr. Tu and the provider leadership, and we're able to solve problems in the moment. And to hear the feedback from the community when we resolve those problems and to have that vehicle has been really meaningful. And as a result of all that work, we're seeing our volumes grow as well. I think it was May or April was the busiest month we had in 5 years at least, maybe longer than that. So the volume, the community is hearing this feedback and they're choosing to come through our ED and stay in rather than go to the surrounding communities. And I could sit up here and talk all day about ED operations. Obviously, that's my passion and I love the team. But those are some of just the highlights and those exciting things that we're working on in the Kaweah Emergency Department. And also attracting, retaining, and promoting really talented individuals. whether that be a physician, a nurse practitioner, a nurse, a mental health worker, unit secretary. We are attracting some really talented people from within this very community that grew up here, and seeing them grow and develop and buy into the vision we're creating. We want to be the best emergency department in the Valley and eventually the state, and that's what we're working towards. So thank you for listening.
All right. Thank you, Cameron. Thank you, Schlene. Thank you, Dr. Hammond. Armando, thank you for hosting us tonight and giving us this opportunity. I want to thank all of you for coming out tonight, taking time out of your family time to listen to us. We greatly value all of you and greatly appreciate your feedback, your perspective, and your comments. And I definitely want to encourage you to ask as many questions as you have on your mind tonight. Anything that we've talked about or anything you're curious about or just interested in. So, so 6 months, 8 months, a year and a half. It feels like, just that I just started. I mean, I can still remember my first day at Kaweah, and that was 34 years ago. It has been an absolute honor and a privilege to serve this community and to help it meet its healthcare needs. I will be forever indebted for having been given this opportunity. Now, Deborah said I had 5 minutes. And for those of you in this room that know me, you have serious doubts that I can actually keep it to. Susie, why are you laughing? I do want to, I'll share a little bit of information with you. The question that I am most asked these days is, Gary, what is the one big, beautiful bill, otherwise referred to as H.R. 1, House of Representatives, Bill number 1, that was signed into law by the President on July 4th, 2025. What impact is it going to have on California hospitals and most specifically on Kaweah Health? So the California Hospital Association, which represents us 400 hospitals throughout California, 33 of us are organized as healthcare districts. So we are a public hospital, like the University of California hospitals and like county hospitals. And I think the hospital on Catalina Island is still a municipal hospital, but we count it among our 33 public hospitals. So the California Hospital Association has estimated that the impact on those 400 California hospitals will be anywhere from $66 billion to $128 billion over the next 10 years in reductions to Medicare and Medicaid, or in California, Medi-Cal, reimbursement to hospitals. So it's taken us a while to figure out how that will actually trickle down to an individual hospital level. But Melinda Tupper, our Chief Financial Officer, myself, working with two very, very bright consultants that work with all 33 district hospitals, we've now got a pretty good idea of what it's going to mean to us. So in the current fiscal year that started for us on July 1st, so our fiscal year runs from July 1 to June 30th. So we're just a few months into the current fiscal year that will end on June 30, 2026. We believe that the impact on us in this current fiscal year will be about $25 million. By the time all the provisions in H.R. 1 mature, which is around 2029, 2030, that it will represent about a $60 million a year reduction in Medicare and Medi-Cal reimbursement to us. So very, very significant. And how that will occur occurs across a number of different elements, some of those which will only impact public hospitals like us. There are a lot of benefits to be in a public hospital, to be in a district hospital, to be in a county or a UC hospital. We do get to participate in funding programs that only public hospitals get to participate in. But those programs are all being impacted by H.R. 1. So I think the thing that is most disconcerting to folks, and again, we'll hit Tulare County hardest because Tulare County, of all the 58 counties in the state, we have the highest Medi-Cal enrollment of any county. 62% of our residents in Tulare County are living at 133% or lower of the federal poverty level. And as such, they qualify for Medi-Cal. 62% of our population, the highest in the state. And so we are very concerned with the new requirements that, number one, Medi-Cal beneficiaries have to work at least 80 hours per month in certain qualified professions or activities to continue to qualify for Medi-Cal. We believe that the majority of Medi-Cal beneficiaries in Tulare County are working, that they are the working poor. But whether they hold their jobs all the time, all year long, to meet those 80 hours, a lot of our Medi-Cal beneficiaries are seasonal workers that work in the fields or work in the agricultural industry that go a number of months without being employed. And will they lose their Medi-Cal funding for those months? And then probably the one that will impact the most is that instead of annually having to recertify your Medi-Cal eligibility, you now have to do it every 6 months. And it looks like it will be incredibly burdensome. Each individual state gets to write their own administrative requirements and the process that you have to go through. But we know for a fact that many of our Medi-Cal beneficiaries will not be able to complete that recertification every 6 months. We as an organization are going to work very, very hard with the county and other agencies to help our beneficiaries achieve that eligibility. So we're going to do our very best. And then the quality assurance fee. I don't know if you guys all remember voting on Proposition 52 a number of years ago. It passed in California and it made the quality assurance fee permanent. That program represents hundreds of millions of dollars to California hospitals, tens of millions of dollars to Kaweah. And so it is being significantly reduced. State-directed payments, a program that only public hospitals participate in. So UCs, counties, and again, district hospitals. So those will be reduced annually over the next 10-year period until eventually it reaches Medicare rates. Right now, it's because of those payments, it actually provides Kaweah with a new revenue stream that we've never participated in before. And to see that cut has been very disappointing. The managed care organization tax, Prop 35, that you all voted for or voted on in November, but it again overwhelmingly passed, it's highly likely that that program is going to be abolished because it will not qualify under the new federal regulations. And then lastly, our Medicare payments, our single largest payer, and this affects hospitals and physicians. But we will see an additional 4% cut in all Medicare payments that are made to the hospital because H.R. 1 is adding $3.7 trillion to the federal deficit. And anytime you add money or add to the federal deficit, then it has to be offset by other cuts. And so Medicare is one of those programs that will be cut. We already endure a 2% cut to our Medicare payments, but now it'll be an additional 4%, bringing it to 6%. But I want to assure all of you, Kaweah Health is a very resilient organization. We have faced daunting challenges in the past, and we have overcome them. I am confident that we will survive this, that we will find a way to remain a very viable full-service hospital that continues to serve this community. But it will not come without some pain and difficult decisions. I don't know if we will be able to continue to provide all of the services that we do today. So stay tuned. We already have found our $25 million in cost reductions or revenue growth to offset this first year's impact on us. But now it will be an ongoing process. But we have an amazing, selfless, dedicated board of directors and an incredible, very talented intelligent executive team that will help us successfully weather this storm. So lastly, I often say, my executive team's probably sick of me saying this, but it's so much more fun and exciting to grow your way back into financial prosperity than to cut your way there. So while we will continue to face very strong headwinds, we're going to continue to grow. We're going to continue to identify new and profitable lines of business or to enhance existing services. Dr. Hammond referenced to an advanced cardiac surgery procedures. Dr. Walter Gribben, a phenomenal pulmonologist that just recently arrived in our community, working with Dr. Gill, one of our medical oncologists, working with our newly recruited cardiothoracic surgeon, Dr. Shelley Banzel, now doing lung nodule screenings and early detection of lung cancer, leading to procedures to save lives and extend lives. So that is a new service that we've brought to our community. We soon will open our child and adolescent crisis stabilization unit here in North Visalia to help children, adolescents, and young adults weather through difficult mental health crises that they may be experiencing. So a facility dedicated to the treatment of those acute mental health conditions. And then we were awarded a very large grant that will help us build a new 22-bed child and adolescent inpatient behavioral health unit that will become a wing of our existing mental health hospital over off Acres. That's probably a couple years away, still in the planning process. Just opened a new rural health clinic in Woodlake, our second in Woodlake on Valencia Boulevard. And then lastly, in supporting the newly recruited primary and specialty physicians that we continue to successfully bring to this community, they need a place to work. And so we are leasing about 13,000 or roughly 13,000 square feet on Acres in the former Cigna building that we now have completely remodeled into a beautiful modern physician clinic and office. So we're just waiting on licensure from the state, and soon we'll be placing physicians and have room to grow. So lots of still very positive things going on at Kaweah Health and in our community. And again, thank you for all your support. Thank you for coming out tonight. And I think now we turn it over to questions, Deborah. And I did go more than 5 minutes. I can feel it.
Okay, I think we're back on. And Gary, I'll forgive you for going over your 5 minutes because this might be our last town hall.
It might be.
You are retiring. So.
I am.
Okay, well, we'll miss you, Gary. Now we're going to open it up for questions. And so if you have a question that you would like to ask, I'll bring you the mic. And if you want to slip me a card, you can as well.
I've asked you this question before.
Yes, Dr. Totten, how are you?
Fine, thank you. Thank you for asking. But how are we currently facing the mandate to improve our earthquake safety in the hospital building? We tried a proposition, I think it was H, a long time ago. That failed. We were considering building out near the freeway. And the last time I asked you, you just kind of looked worried and said, still thinking about it.
Well, thank you for that excellent question. So yes, Senate Bill 1953 passed into law back in, I think it was 1999, right after the major Northridge earthquake that occurred in 1994, caused serious damage to hospitals down in Southern California, resulted in the evacuation of those hospitals and long time to repair them. So yes, the Mineral King wing of our downtown medical center, which opened in 1969, houses 206 of our medical surgical beds. So when you think of 2 north, 2 south, 3 north, 3 south, 4 north, 4 south, all of those units and those beds are located in the non-seismically compliant Mineral King wing, along with our cafeteria and dietary and pharmacy and a number of ancillary services. While there have been many attempts to amend Senate Bill 1953, none of them have passed. And so the original law and requirements are still in place, which would not allow Kaweah to use the Mineral King wing for acute inpatient care beyond January 1, 2030, which we've exhausted all possible attempts to see if we could actually renovate, retrofit, somehow bring that Mineral King wing into compliance. It would require that we'd have to shut it down for about 2 years, and the amount of cross beams that we would have to install, you'd be ducking your head everywhere you walked, and it would really not be operational. So we've spent a number of years designing and planning to build a replacement tower just immediately west of the Acequia wing. So essentially what's in our visitor parking lot in front of the Acequia wing tower. Our estimated cost to build that was going to be a 10-story building. It would replace all 206 beds plus 34 additional beds, so 240 in total, at a cost of probably close to $800 million. So Measure H, which we went to the voters in April of 2016. We asked for $327 million in property tax funding, and unfortunately, we failed miserably. We only garnered 42% approval, and a general obligation bond requires 2/3 approval. So in the meantime, COVID arrived, lots of things happened. We turned our attention away from that and really to trying to get through COVID and then get ourselves back on our feet financially. And so we kind of had put that aside, except for certain people in our hospital, like Mark Mertz, our Chief Strategy Officer, and Kevin Morrison, our Director of Facilities and Maintenance. They've kept busy at following the developments along the way. I don't want to jinx it, right, Mark? So I got some incredible news on, I think it was last Friday. I met with Mark and I met with Kevin, who just recently met with the HCI, Healthcare Affordability and Information. It used to be OSHPD, which I remember what that stood for, but now it's HCI. Essentially, HCI oversees all hospital buildings and codes and things of that nature. And so there's a category called SPC4D, as in dog. SPC stands for Structural Performance Category. Our Mineral King wing is SPC2. There are 5 levels, 1 through 5. If you're level 1 or 2, you cannot use that facility for acute inpatient care past 1/1/2030. SPC 3 and higher, you can indefinitely. But there's a special category for hospitals that were built before 1978 called SPC 4D. We've never been able to qualify for SPC 4D until maybe now. And the reason is, until now, HCI has been unwilling to allow hospitals like us to do computer modeling of how our facility might perform in the event of a major earthquake in this community. And one of the key measures they look at is drift. So you think of the hospital, most hospitals are meant, especially newly built hospitals, are meant to sway a little bit in the event of an earthquake. But there's a measure. A 1% sway or drift is all you're allowed to be seismically compliant. The computer model indicated that we're at 0.84 or 0.89%. So quite a bit below the 1%. And the 2 senior engineers at HCI that Mark and Kevin have been working with came away from that very optimistic that Kaweah will qualify for SPC 4D. We will submit all of the paperwork and everything by December 31st and learn if we do, but I think there's better than a 50% chance that we will qualify, which will allow, I mean, we still will have to do some upgrades. We'll have to do some reinforcement of some of the walls and the connections, but they're fairly minimal and very affordable. And so if we meet those, then we will be able to use the Mineral King wing indefinitely. Thank you for that question.
Thank you, Gary. Does anybody else have a question?
Thank you, Deborah. Gary, a few months ago, we were worried about something, $47 million of FEMA funds. You smile. Is that still, we're still working?
You guys are throwing me softballs. I love it.
Well, you want some hard? There you go.
No, Sam, yes. So COVID, obviously, was a terrible experience for all of us across the entire world. Not only loss of life and how it changed lives across our country, certainly in our community, something we hope to never experience again. We spent a tremendous amount of money just protecting our staff from contracting COVID. Wearing personal protective equipment every day, our nurses 12 hours a day in gloves and gowns and masks and face shields and at the same time taking care of patients. And so it definitely took its toll on our staff, but it also took its toll on our bottom line as well. And so when the president declared it to be a national disaster, it then became eligible for FEMA funding. So what the Federal Emergency Management Agency, which normally handles floods and fires and earthquakes and natural disasters of that nature, we were allowed to file applications seeking reimbursement for those COVID-related expenses that we incurred, which again were substantial. That we spent $150 million alone on traveler nurses. At one time, we had 250 travel nurses that we were paying anywhere from $250 to $300 an hour to staff the hospital. And so the aggregate amount of our FEMA claims was $47 million. And we received 2 checks for $47 million in total this summer. And so while it was a long, arduous process, we were successful. They mailed us paper checks. We thought we would get a wire transfer, but they mailed us paper checks. What was aggravating is they were dated in May, and we didn't get them till like August. So the state was holding on to them as long as they could to earn a little bit more interest income. But it allowed us to do a 100% match of our employee 401k plans, and then to kind of replenish our cash reserves that had been severely depleted during COVID. So I think our number of days cash on hand right now is right about 100. The lowest point was at 62 back in March of, it was 21 or 20, I think March of 22. We have to be above 90 days to be in full compliance with all of our debt covenants on our bonds and other debt. So now we've got a little bit of cushion above that 90, but we want to continue to rebuild it. But it's going to be tough, obviously, as we face down HR1.
So that mean you got me $18 million back that you had to put up with bond?
No, thank you for that. So because we fell below those 90 days and stayed there for a while, we did not meet our debt covenants. And so unfortunately, Moody's downgraded our credit rating from an A3 stable to a BA1 negative. A BA1 is below investment grade. So you've heard the term junk bonds. Unfortunately, our revenue bonds, and we have over 200 million that are outstanding that are held by investors who buy Kaweah Health municipal bonds. While those bonds are still very solid, and we intend to pay every penny of it back, the interest and the principal, because we had fallen in, not default, but non-compliance with the covenants, the bond trustee required that we take $18 million of our cash reserves and put it in a trustee bond reserve account. We can't get that money back until we've gone 2 years of meeting the debt covenants. So we've met it now for a full year. We've got to meet it again through June 30, 26, and then we can ask for those funds back. It's still our money, and it's still fully there, earning interest. It's on our balance sheet still, but we can't touch it.
Okay. Any other questions? Okay, Gary, it was recently announced that we would not be providing prompt care services at the Maddox location. So what are we still going to be offering at that location?
Yes, so the clinic kind of on the corner of Maddox and Tulare in southeast Visalia has been both a primary care clinic and a walk-in clinic. So Dr. Bill Roach, family medicine physician, Dr. Esther Flores, pediatrician, Dr. Solonik Tays, a family medicine physician, they're all still there in that Ben Maddox clinic, still seeing patients, adults and pediatrics that are their patients, that those providers have a relationship with those patients. So we no longer are taking walk-ins because we found it very difficult to staff walk-in patients, and to have the staff of the walk-in patients there and the staff our urgent care center in Court Street, which are fairly close to one another. And so having to duplicate the staff and the providers, we determined that, again, to be more cost effective, to be more efficient, to better use our resources, that we would consolidate the walk-ins at Ben Maddox with the urgent care center on Court Street. So that has occurred. At some point, Dr. Roach, Dr. Solonik Tays, Dr. Flores will move to our new clinic on Acres that I talked about earlier. But we will continue to recruit more primary care physicians and nurse practitioners, physician assistants. So that may allow us to open back up Ben Maddox for walk-in visits. I don't know how soon that will be, Deborah. It is very, very difficult. Most urgent care centers are generally staffed by a nurse practitioner or a physician assistant with a physician that oversees and supervises and manages those advanced practice providers. Advanced practice providers are in increasing shortage. There are so many, physician offices, clinics, urgent care centers that are using advanced practice providers more and more and more to increase their access and availability, which is a good thing for us as patients. But it's making it much more competitive and more difficult for us to recruit APPs as well. So I hope that's temporary, Deborah.
Thank you. So Schlene, this question is for you. At our previous town halls, especially really since COVID, we've talked a lot about the shortage of nursing, and we've talked a lot about new nursing and different things, travelers. So can you give us an update on the status of our nursing, and if we still have travelers, and what you're doing to just encourage our nurses?
Thank you for that question, Deborah. Actually making sure that we have a core of nurses is one of the top priorities for me. We do still have travel nurses, but I will say over the past probably 2 to 3 months, we have been able to reduce a number of our travel nurses. What we have done is made sure that we offer opportunities for them to become full-time permanent nurses. So worked very closely with our leadership team and our human resources department. And we have been able to transition a lot of our travel nurses over to permanent nurses, which is really good. Additionally, I'm very happy to join Kaweah because of the fact that the organization had already developed a number of relationships with area colleges. So I believe we have at least 3 to 4 partnerships with various colleges in the area. And so we have a pipeline. And what is very important for me and what I'm doing with the leadership team is ensuring that we are able to provide great support and a great foundation for these nurses because they will be fresh nurses transitioning into practice. And so what my absolute priority is to make sure that they have a great training opportunity, that we are there with them elbow to elbow, and we train them up to be great nurses. So that is another great privilege that I have here to really be leading nursing in an organization where I have an opportunity to really impact these nurses that will be new to nursing. And we have several classes that graduate almost probably every 2 to 3 months. We're getting new nurses that are transitioning into practice. And I know in January we're going to get a significant number. I believe it's like our one of our first cohorts, and then we'll have some more coming in. But again, Kaweah has done an exceptional job in being able to provide careers to a lot of the nurses, or well, I would say a lot of the employees that work at the organization that have wanted to go into nursing. Almost every day I meet nurses that started off as CNAs working in dietary and lab and different areas. So a lot of great things that are happening as far as being able to help us to combat the nursing shortage. And again, I think just the challenge will be for us is to make sure that we train them up to be the great nurses that we want them to be and we know that they can be. So a lot of work being done in that space. And it's going to be great. I'm very excited about it.
Awesome. Thank you, Schlene. So Cameron, you mentioned in your statement that we hit the record of, I believe you said 340 patients in one day. And it's not even respiratory season. So what are you guys doing to prepare for what we know is going to come in the December, January, and February months?
Thank you for mentioning that and giving me anxiety as we face the upcoming months. Historically, October is a bit of a low month. We had a very busy and active summer. We saw high volumes through that. And then October, we're getting a little bit of a breather, but we are not taking any days off. We're looking towards the respiratory season that's upon us. And to Schlene's point, we are attracting, retaining, and promoting at an aggressive level. The community has these sources of trained medical professionals, and we are getting out in the various colleges, and we're just getting really aggressive with making sure we are going into every shift fully staffed for those volumes that we're talking about. Because we can't change the volume, but we can certainly work on our strategy. And it starts with making sure that we are staffed. And then I talked about that front end process. We're a much more efficient department now in separating the critical traumas that come in through our ambulance and then all the volume through the front door, which is that historical viral processes that we see at this time. And if you haven't seen it in your family yet or in your communities, it's out there, I guarantee you, because we're seeing it in our department already. Our colleagues are starting to get sick from the volumes of, and we're seeing a little bit of COVID involved in that. It's not as severe as it was years ago, thankfully for that, but we are seeing all these viral processes starting to rear their heads. And it'll continue into the next year. So hopefully that answered your question at some point.
It does. Thank you, Cameron.
Yeah.
So Dr. Hammond, you mentioned the reason why you stay here in the community. And Gary was open when he was talking about how the lack of physicians in this area is kind of a struggle. And we are desperately trying to recruit physicians. So what's your suggestion for getting more physicians to this area?
Yeah, thank you for that question, Deborah. I think it's developing homegrown talent. So we're very lucky at Kaweah that we train a number of young doctors. Many of those young doctors are getting the kind of experience here that, honestly, I've been in some very large hospitals. The kind of consistent sort of challenges that we have, the kinds of pathologies that our patients present with, the kinds of and severity of illnesses that our patients have, really are incredible opportunities for our young doctors to learn. And I think that if we set the tone, that the satisfaction level from serving your community is so high, the support is there, and the challenges are there, we hope that we can continue to retain the young doctors that we're training at Kaweah in our community. One of my personal background includes training critical care doctors, very advanced, board certified critical care doctors, training lung doctors, training sleep doctors. We are working with Angel Smith, who's one of our new academic leaders that helps with our trainees, to hope in the next year or two we'll have an avenue where we can start bringing more internal medicine trainees into Kaweah, and I would hope open the door for us to train GI doctors and cardiologists and critical care doctors and people that are here because this is their home. We can, I think, advertise and get a lot of talented people here, but they're usually going back somewhere else. The way that we make a difference is we get people like me that come that have no idea where in the world Visalia is until they show up here and realize that not only is Visalia a very special place, but Kaweah is a very special community with people that have generations and generations and generations of roots here, that appreciate the care that they get in a very deep way that really humbles me almost on a weekly basis. We're humbled by the generosity and the appreciation that our patients and our families show us. And that kind of reward, I think if we can get enough people here to see that, will help us keep people here in the community, because I think ultimately, and the community's big. I mean, it's not just Visalia, obviously. There's a big catchment area for Kaweah, but I think that that's really the best approach to make sure that we have that really robust medical staff that's not only very talented and can do the job, but understands the heart of the institution and the heart of the community, and feels very gratified by being able to be part of that.
Mm-hmm.
Great answer. Dr. Hammond, you moved to Three Rivers. Mark Wirtz is a Three River person. If you wander through our hospital, you see Larry Lewis's photography everywhere. And I understand Mark has them in his office. I know they're in just about every campus site we have. Larry Lewis, who did the photography, does a lot of it in the Three Rivers area. At our Rotary meeting 2 weeks ago, he presented 80 slides over the course of 20 minutes on the Sierras. And half of Tulare County is in the Sierras. It's, Kaweah, or this Kaweah National Park and Kings Canyon. And I suggested to Ms. Cocaine that we include some of that slide work in advertising for the GME type folks. I hosted a doctor for 22 months, and we spent a lot of time in national parks. We have an asset here that's not just nothing against farming, but for the folks like yourself that love the mountains, I would suggest that might be something that could be incorporated into our marketing for GME type folks.
That is such an excellent idea. Number one, Mark, I need a tour. So you got to show me those pictures. And number two, I spoke with a potential physician today that's looking at, potentially coming to our community. And we spent a lot of time talking about that, because when you live in Los Angeles or when you live in San Diego or San Francisco, there are so many things that you have to compromise on. And as I've stayed in this community longer and longer, I found that there are less and less compromises that I'm making. I thought that I'd have to give up a lot, not practicing medicine in Los Angeles, but what I've gained is pretty incredible. And part of it is just having the beauty, my drive in the morning from Three Rivers. It was better before it got darker outside, but and before Lake Kaweah sort of got a little low on water. But, driving back and forth just reminds you of just how majestic this part of California, this part of the world is. So I fully agree. I think that that's a great idea. And I think we've got the decision makers, we've got the deciders here, so maybe we can get that done. But that's a great idea. Thank you.
Okay, does anyone else have any questions? Any questions? Okay, so as the Director of Patient and Community Experience, I'm just going to do a really quick roundtable. And let's start with Cameron. Cameron, what's the number one thing the emergency department is doing for patient experience? And then we'll just go down the table.
Whoa, the number one. Oh gosh, I think it's a accumulation of everything in the ER, because we have to provide fast, factual, and friendly care. That's what the community wants. That's what they deserve. So reducing length of stay is our next big focus. Because if we can promise to the community, on average, you're in and out of our department within 2.5 hours. On discharged home patients, which is 80% of the patients that come through our ER go home. We only admit 20%. So if we can get that number down, I think that's a promise to the community that they will, they'll love that.
Same question, Schlene.
So-
What's the top thing that comes to mind about patient experience?
Yeah, just being very authentic and showing empathy and compassion for our patients. That is absolutely number one, what I am striving for and what I am requiring for every nursing leader, every team member. That is absolutely what we are stressing, and that's what we are striving for. So for a great patient experience.
Putting you, Deborah, and Mark Mertz in charge of patient experience is one of the best things I've ever done. And supporting your onboarding of some very talented individuals that are supporting you, and bringing our executive team to the bedside. So every month now, each and every one of us, me included, we go up onto the floor and we go into patients' rooms and we sit down with them and we introduce ourselves and we talk to them and see how they're doing and what we're doing well and what we could be doing better. I was in the emergency department just a couple weeks ago rounding. I even went in and sat with a mental health patient in Zone 4 and had a wonderful conversation with him. He wanted to know how he applies for the CEO position when I retired. So he was a lot of fun to talk to. But no, Deborah, I owe a lot of our improvement to you. Thank you.
Same question.
Same question.
So critical care medicine is definitely a team sport. And I think one of the things that we've really tried to do in our intensive care units is have something called multidisciplinary rounds. So from 9 to 10 every morning in our critical care unit, we go from room to room, in front of the patient room, include the family members, have a discussion about what the urgent issues are that day, what the plan is for the day. We discuss it with our nurses, with our occupational therapists, our respiratory therapists, our social workers and case managers, our trainees. Everybody sort of moves in this very, sometimes a little disjointed pack, but we move through the unit. And by having that visibility, and I think by also including patients, and oftentimes palliative care, I see our palliative care doctors are here as well, in the discussions, we can identify areas that we really need to all come together to help with. And it also gives every patient's family an idea of what's on our mind that day. Sometimes hard to track down doctors during the day. We get busy, we get distracted. But from 9 to 10 every day, we're in front of a patient's room, we're available to the family, we include them, we include everybody on our team, and we collaborate to give the best care I think we can.
So I think my favorite thing that patient experience has done is placing somebody in the ER to assist with families that are waiting there, to kind of keep them connected to, where they're at. A lot of the times people are sitting there for, not anymore, but before it was hours, right? And not knowing what was going to happen or where they were in line. So currently, just recently, how long has it been? Maybe 2 to 3 months that they've been there? 2 months.
Month and a half.
Month and a half. So now there's a person in the ER that talks to our patients, letting them know like where they're standing in line and what the processes are, so they don't feel as disconnected, or they know what's going on, so they're more at ease. So I think that's a really big thing that patient experience has done. So thank you.
All right, thank you for that. So are there any other questions? Yes.
You don't get a chance to ask like this very often. Recently, I needed to have an x-ray of my foot, and I thought, oh, it really hurts bad, so I thought I'd go over to the Court Street facility. I got there 8:15, something like that, and I was told that, they're kind of booked all the way up till 9 o'clock, come back in the morning. But hearing that you're maybe shutting down the facility just to the east of that, is there any possibility to have that facility or one like that work more hours to take a little bit of the stress off of folks that have to go to ER at that time? And I don't know if there's a bubble of people coming to the ER at 9:30, 10 o'clock because they can't go to the local walk-in.
Yeah, I think, Sam, again, one of the reasons that we consolidated is we didn't have a lot of walk-in volume at the Ben Maddox clinic. So I don't know how much consolidating will actually impact access or availability in the Court Street Urgent Care Center. But I know that Ryan Gates, who is our chief ambulatory officer, he oversees all of our clinics and our 2 urgent care centers. He has been looking at expanding hours, maybe an hour later in the night, and being more available on the weekends as well. I know one thing we're really looking at, and I know it's very frustrating to people. We are all used to when we go to an urgent care center that you walk in and you get in line. The waiting room might be full, but you're going to be seen, and so you sit there in the waiting room waiting for your turn. Now, if you walk into a Kaweah Urgent Care Center, it might look like the waiting room is empty. There might be one person there, maybe nobody there. And you're walking in excited that I'm going to get right in. And then they tell you there's no openings, and you're looking around. What do you mean there's no openings? Well, people go online now. They use Clockwise, I think is the name of the system. And so instead of sitting in a waiting room around maybe a lot of sick people, you can now wait in your car or you can wait at home. And you actually go online and you schedule your urgent care appointment and you walk in shortly before then. The people that have used that love it. However, finding an appointment, they book up so fast, or the people that walk in, we'll still see you if there's room. But so we're addressing that. I mean, should we go back to the old way that people are used to? We definitely are recruiting heavily for more advanced practice providers. That's the linchpin, the ability to see more patients and to extend the hours is all predicated on having a sufficient number of providers. So we're not there yet. We're working with our recruiters. We think we're very competitive in terms of compensation and benefits, but it's still a struggle.
That model appears to work pretty well in the walk-in clinics. Is it possible in the ER side?
Probably not, but I'll let Cameron.
Yeah. So to your point, the ER can be a convenience for the community. When everything else shuts down, we're open 24/7, 365. So we do see an influx of patients towards the evening, and we answer that call. So for us, not knowing when and where it's coming, we look at the volumes and we staff to that and build our processes to be efficient for those x-rays that come in the off hours. And we're confident in what we've built and what we've got going on, knowing that you come in at 9:30 p.m. for your foot x-ray. We get you in front of a provider quickly and get that ordered and get the actual x-ray performed. And then we have to wait for the radiologist to read it sometimes. Dr. Tu sometimes does some wet reads. But we control what we control, and then we let Gary and the team design and develop the other side of it. So I wouldn't want to speak to processes, but we are heavy in the APP. We utilize them really well to offset our physician leadership. So at any time you come in the ER, you see physicians assistants and nurse practitioners performing at a really high level. And so that's one of the things we're very proud of and must stand by.
Well, I just thought of, since you're talking about scheduling, thank you so much for making it possible to schedule lab appointments now. That was a nice, but thank you. But I just want to say thank you, Armando, for hosting and for having these town halls. And it really warms my heart, having lived here my whole life, to see physicians and professionals and everybody want to live in Visalia. It's like so wonderful, because it hasn't always been that way, as I'm sure Armando knows. And for the transparency that I've seen grow over the years. Also, I just wonder if anybody has any pointers on, we all know things are kind of chaotic in the world right now, and people are worried about their health care. As community members, do you have any recommendations when we hear somebody talk, what to say to them? Is there anything to say?
The only non-clinical person grabs the mic. It must be a disease I have. Or, no, it's a great question. And the reason I grabbed the mic, because I mentioned that I was rounding in the emergency department, and I walked into zone 1, which is kind of intake, where you start out when you first get back to a provider, and there was a mother and her daughter there. And I sat down with them, and they expressed the exact same concern. And they were also worried about Kaweah. You know, they saw Tulare Hospital close for a couple of years. It's since reopened because of Adventist Health. They saw Madera Community Hospital close. I was at a district hospital leadership forum committee meeting Monday and Tuesday of this week, and learned that 3 of our 33 district hospitals are in bankruptcy and are likely to close. So hospitals up and down the state are struggling. And I think that understandably causes a lot of concern and anxiety for a community like ours that depends heavily on a lot of people move to Visalia, you know, because they know there's good healthcare here and good schools, and, you know, safety and health and education are the 3 pillars to a thriving community. And so I do get those questions. You know, I remember during COVID and just the challenges we were going through, an older couple from LA were moving here, and the first thing they wanted to know, will Kaweah be here for us? We're concerned. We've heard the challenges. We're not going to move if, you know, this hospital is not going to be here for us. And so I want to assure you that this hospital plans on being here another 60 years and beyond. I am confident in that. We have, again, an incredibly talented and dedicated board and executive team, and our 5,200 employees, our 700 physicians and advanced practice providers are all dedicated and committed to making certain that Kaweah will always be here for our community. But definitely, from a healthcare standpoint, you know, establishing a solid relationship with the medical community. And we can certainly help in that. When new people, you know, they move to the community and they're looking for a primary care physician, we have the ability to connect them. We work with the Tulare County Medical Society to always be aware of which physicians are accepting new patients and so forth. And so, Yeah, I mean, definitely, as we bring in more physicians, more ologists, gastroenterologists and urologists, and, trying to do our part to make certain when our community needs healthcare that we've made it available for them and that it's here in our community. You don't have to travel far. So I know there's still a lot of anxiety just right now, what we see going on in the world and our society, and it's so gut-wrenching at times. But Kaweah has not lost our compassion, our empathy, our deep, sincere, genuine care for our community, and the honor and the privilege to take care of our patients.
Gary, I'm going to ask about the GME program.
Yes.
There's been talk about reducing and maybe changing some of the amount that you're going to be putting in different departments, and maybe it's adding on internal medicine, and definitely we need all of those. But is there any plans to expand the GME program and the number of residents that we can get, so we're not losing in the departments that are already using them?
Yeah, great question. So when a hospital first starts a graduate medical education program, which we did back in the summer of 2013, you have 5 years to build your entire GME program, to identify all the different residencies that you're going to provide, the number of slots that you're going to provide, submit your applications, become accredited by the ACGME, hire your faculty and program directors and everything, and you have 5 years to do that. And if you do everything you do in that 5 years, then will be funded indefinitely by the Medicare program. You can add residencies and more slots in residencies after that 5-year mark, but there's no funding. Medicare will not pay for it. And a lot of hospitals operate outside their cap, is what it's called. So we started a child and adolescent psychiatry fellowship program a few years ago, beyond the 5 years. And so that program is entirely funded by us. Nothing comes from Medicare or any other organization. We just recently added 2 additional anesthesiology slots to our existing anesthesiology program. Again, unfunded, outside the cap, but we felt it was so important to support our anesthesiology program and services, and we need more anesthesiologists in this community. So we can do that. You also can swap out. You can take a couple slots in one residency and move them to another, or, so Dr. Tu and I and others have been talking about emergency medicine. It's our single largest residency program. It started out, it was one of our very first back in 2013. It had 6 residents, a 3-year program. We then increased it to 10 while we were still inside the 5-year cap, and then grew it to 13 while still inside the 5-year cap. So every year now we graduate 13 emergency medicine residents, and we have graduated well over 100 since our first class of 2016. Unfortunately, our retention rate is only 6.6% of those graduates, those EM graduates, are still here today. So it's a wonderful program. Dr. Tu, Dr. Oldroyd, Dr. Singh do a wonderful job, but maybe that program is too large. And we desperately need internal medicine. We desperately need primary care. So internal medicine is also a 3-year program. So it is possible for us to take some of those emergency medicine slots and convert them to internal medicine and get paid for them, because the Medicare funding would still come over to a different residency. So that's one that I have been seriously contemplating actually for the last couple years. When Dr. Lori Winston was our designated institutional official, I started talking with her about, other residency programs. I'd love to see us start one in neurology, gastroenterology, OB. We deliver almost 5,000 babies a year. We should have an obstetrical residency program. Now, we're getting close to the end, so I will, if I can, end on a very positive note. Guess who signed Senate Bill 246 last week? The governor. Senate Bill 246 will provide $15 to $20 million a year in new funding to the 5 district hospitals that have residency programs in California. Kaweah is by far and away the largest. Sierra View has an internal medicine residency program, 11 slots. There are 3 other district hospitals that have small teaching programs. So Kaweah is likely to receive the vast majority of that 15 to 20 million a year in new graduate medical education funding that can be used to fund existing programs, that can be used to start new programs. So even though we won't get any additional money from Medicare, we now have a new funding source that does not have a sunset date on it. We still need CMS, the feds, to approve it, but it's the exact same program that the UC and county hospitals have enjoyed for years. So we're just kind of piggybacking onto an existing program, so we have a high degree of confidence that it will be approved and that the funding will start flowing on January 1, 2026.
Music to my ears.
Representative from the authors of it and co-author.
Thank you. Please express our sincere gratitude. This was Senator Shannon Grove and Assemblywoman Ana Caballero, who co-sponsored the bill. It sailed through both the Assembly and the Senate with 0 opposition, but Governor Newsom could have still vetoed it, which he has done in the past, even on bills that sailed through with no opposition. So we were definitely crossing our fingers and heard word last week that he had signed it. Yes, Dr. Todd.
Another question. You've already sort of brushed on it. My patients are complaining that there is no obstetrician that sees private patients in town, although we're delivering lots of babies here. And there's clinics. And as family practitioners, we're doing a certain amount of prenatal care. But so anybody on the horizon?
Yes. Well, we are all very disappointed to see the Visalia OBGYN group close its doors on December 20th. The group has dissolved and everybody's kind of moved on. Dr. Mark Wiseman has stayed in town, but he's only doing gynecology, no longer delivering babies. Dr. Boken, Lorianne Boken, went to Sierra View and Porterville. Dr. Bosman left town. But we were fortunate to keep Dr. Holly Quinn. Dr. Quinn is a phenomenal obstetrician, but she herself just had her second baby, and she's on maternity leave, although I think we expect her back later in November. And she will once again return to full-time practice in our 202 West Willow building, the 5-story right next to the helipad. Rita Barron, also a very, very beloved midwife in this community that was part of that Wiseman group, she became a Kaweah employee, and she is working with Dr. Quinn. Dr. Sabagal, Dr. Ronhell, who work primarily in our Exeter and Lindsay clinic as obstetricians, are now coming over to 202 West Willow in Visalia as well to support Dr. Quinn and Rita Barron. We are actively, aggressively recruiting for more community obstetricians to join us. We have made many offers out there. Some are being contemplated right now by the candidates. They all tell us that our offers are the best they've received from anybody, so we know that we're being very competitive. We also, on July 1st, we welcomed OB Hospitalist Group from South Carolina, came to town. We contracted with them to serve as our obstetrical hospitalist group. So these are board certified OBGYN physicians that practice at Kaweah. They're in the hospital 24 hours a day, 7 days a week. They deliver any mom that doesn't have an established obstetrician. we would consider it an unassigned mom. They deliver all of their babies. They will deliver any baby. Where, say, our community obstetricians or Family Healthcare Network or Altura, if one of those moms shows up and that their obstetrician can't get there in time, OBHG, Dr. Kano, Dr. Hammond, not Hammond, Hammond, phenomenal obstetrician, they will deliver their babies. The best thing about this, though, is we're finding, like Dr. Quinn, like Dr. Runhell, who are young parents, they don't want to get up in the middle of the night anymore or on weekends and come in and be delivering babies all night long or on the weekends. And so OBHG will deliver their babies for them. So they make arrangements with community obstetricians so that Dr. Quinn can say, after 7 o'clock at night, I want OBHG to deliver my mom's babies. Or on the weekends, I want them. And so it's a phenomenal service. So not only delivering babies, but, a lot of moms that come in not ready to deliver, but they're spotting or having pain or something related to their pregnancy, they don't go to the emergency department. They go right up to the second floor of our East Tower where our labor and delivery triage unit is, which is essentially an OBED. So they staff that. They respond to the nursery. They go down to the emergency department. And so we think this new relationship with OBHG is actually going to make Kaweah and Visalia a very attractive place for young obstetricians to want to come here and practice. Yes, thank you, Doc. And Dr. Totten, did I understand you are joining Dr. Solonik-Tays and will be working in our Acres Clinic as well? All right, I'm delighted to hear that. Congratulations. Thank you.
Okay, does anybody have, okay, wait.
Thank you very much for letting me, for giving me the opportunity to speak. My name is Peet. I'm one of the nurses in the emergency department. Gary, I did have one question. It will touch into kind of the two previous questions about GME. We did touch on today's topics of how the emergency department has had improving numbers of length of stay and door-to-dog time, and how these numbers have led to a 10% increase in statistics. In return, these numbers also lead to improved patient satisfaction scores. The concern comes if there is to be a reduction in the emergency resident GME class or cohort. The idea that what comes to my mind is that it's going to affect the door-to-dog time because there's going to be less doctors to see said patients. With there being over 100 more patients a day over the last year, where we used to see about 220 over the last year and a half, and now we're seeing 300 plus average on a day. These things come into my mind and worry that if there is a significant reduction of these EM residency slots, and how we will go back to negative patient satisfaction, increased length of stays, and increased door-to-dog times. I also understand that GME residency is important for the future and perhaps for other pipeline residencies. So I would like to know what your thoughts about that is.
Yeah, great question. So in fact, I attended a meeting today, and Angel Smith, our new designated institutional official, who comes with a deep wealth of knowledge in establishing and operating GME programs, and has done that in many areas across the country. So she has already been working. I don't know if Dr. Tu has been involved in this. I know she's met with Dr. Singh and with Dr. Oldroyd. So at any given time, there are about 13 residents that are in the emergency department. And she has been working on a new rotation schedule of the residents and under a smaller size. I think she's looked as small as 6, which was the original size of the program, as well as 8 if we were to shrink to that size. And by changing the schedule of the rotations, she has been able to create a staffing matrix that essentially still puts 13 EM residents in the ED at all times. And so even though we will have fewer than 39 residents in the program, still able to maintain the same number of residents in the emergency department as what we pretty much have now. Now, I also say the ACGME greatly frowns on using residents as part of the service, to using them to staff the service as opposed to attending physicians. And so, they're there to learn. They're not there to supplement physicians. And so we have to be very mindful of that we want to create a great teaching experience, learning experience for our residents. And if we oversaturate a particular program, it really can dilute, the effectiveness of that learning experience. And we want to graduate highly skilled, competent, confident, physicians. So, which is probably why the ACGME is seriously looking at expanding or changing the EM residency program from 3 years to 4 years, because they can start appreciating that extra year of training helps build that confidence and competence. So I'm very mindful of that. Again, this is something we've been looking at for at least the last couple of years. I definitely don't want to do anything that is going to diminish the gains that have been made, and they're phenomenal. And I want to thank you, your colleagues, Dr. Tu. I was giving a shout out today to Scott Baker and Dr. Tu for the great work that they've done in the ED. And so we certainly don't want to go backwards. So I appreciate your comment.
Thank you very much, Gary.
Okay, our time is up. And
Okay.
so I kind of made a clip, Gary, when I said this might be your last town hall and blah, blah, blah. But I really want to say that in 2017, you made a commitment to transparency. And you have never wavered from that. And town halls developed from that. Our community advisory councils developed from that. So thank you so much for always being willing to sit behind a table, to sit behind a camera, to stand up in front of people and answer tough questions. And I know we appreciate that. I know the community appreciates that. So thank you very much. Thank you to all of our panelists. Armando, thank you for putting this town hall together with Lizette. And it was your idea, and thank you so much for getting that going. Thank you, Dr. Hammond, Schlene, and Cameron. We appreciate the time that you guys spent with us. And thank you all for coming out. We've been dealing with some sound issues and whatever's flying up over our head. I have no idea. But thank you for coming out.
Great.